We are doing our patient case study on influenza associated with ARDS. I'm Ariel.
My name's Renee.
And Lynn.
And starting off, our clinical presentation and initial management begins. The situation of this patient is due to intubated to respiratory failure. We begin with a 38-year-old previously healthy male who presented to an outside hospital with a short history. Just 1 to 2 days of fever, sore throat, cough, and chest pain. A rapid influenza test confirmed influenza B. He was discharged home on Tamiflu and symptomatic treatment with Tylenol and Toradol. Here we have a background timeline over the days of this patient's care. In less than 24 hours later, he was brought back in by ambulance. His family reported altered mental status, persistent nausea and vomiting, and complete inability to tolerate oral intake. This raised significant concern for systemic involvement in dehydration. As you see with the timeline of the background, patient's history, February 8th, the patient had a fever, cough, and sore throat and chest pains. By February 9th, that shows where the patient was brought in by ambulance from an outside hospital with an altered level of consciousness. By February 10th, patient was transferred to CPMC Venice for ongoing management. And then later by February 12th, patient was transitioned to comfort care. During those days, our group will give you more information on management. The patient's clinical deterioration and an ICU transfer. Here we have the patient's history from February 8th to the 10th. On readmission, the patient was in severe respiratory distress and hypoxic with declining mental status. Emergent intubation was performed with an size 8 ET tube placed at 28 centimeters at the teeth. Initially set on volume control, assist control, the patient could not be ventilated effectively. So he was switched to pressure control assist control with a respiratory rate of 14, pressure control of 26, a PEEP of 8 centimeters of water, and an FiO2 at 60%. His tidal volumes were around 500 milliliters, which is marginal for adult males, suggesting decreased lung compliance. Labs revealed neutropenia and thrombocytopenia. Empirical antibiotics were started, cefamime, deoxycycline, and vancomycin. A bronchoscopy revealed about 50 milliliters of alveolar hemorrhage, another indicator of severe lung damage. Imaging showed bilateral opacities and mediastinal lymphadenopathy consistent with ARDS. Indications for VA ECMO. Despite all efforts, the patient's condition deteriorated rapidly. He developed worsening respiratory acidosis with hypercapnia and hypoxia. He required escalating pressure support, suggesting hemodynamic collapse. On February 10th, he had a cardiac arrest at 7 a.m. and achieved return on systemic circulation after 15 minutes. A second arrest occurred less than 2 hours later. A Lucas device, which is a certain device that can mimic chest compressions on a patient without having some sort of medical staff doing it themselves. He was then cannulated for VA ECMO about 10 minutes into the second arrest. VA ECMO was chosen because it supports both respiratory and cardiac function. At this point, he had a clear indications, low cardiac output, hypotension, unresponsive to pressors, and profound hypoxia. ECMO allows circulation to continue while his heart and lungs were sessioning offline.
Okay, so this is Lynn, and we're getting ready to dive into the pathophysiology of influenza related to acute respiratory distress syndrome, ARDS. So let's talk about what happens internally. The virus replicates within local macrophages, causing cytokine release. The release of them activates the inflammation process. Recruitment of additional immune cells amplifies the cytokine response. With inflammation comes an association upregulation, where a cell increases its response to a signal, often by increasing the number or activity of receptors on its surface. The mechanism to restrain immune response and preserve local tissue. The downregulation, reducing or suppressing a response to stimuli of inflammation may not always occur, resulting in overabundance of inflammatory cytokines. On the next slide, the patient likely experienced viral pneumonitis that progressed into acute respiratory distress syndrome, ARDS, a condition where the alveolar capillary barriers become disrupted, leading to fluid leakage, impaired oxygen diffusion, and poor lung compliance. A bronchoscopy was an imaging supported this with findings of hemorrhage, inflammation, and bilateral infiltrates. As you can see from the X-ray image, segments of the lungs are scattered, patchy, and cloudy white dense opacities. Several causes that could lead to these infiltrations are infections and inflammatory conditions, where the alveolar capillary barrier becomes disrupted and leading to fluid leakage and impaired oxygen diffusion and poor lung compliance. My next slide, the key driver of this kind of deterioration is often called the cytokine storm. This is an overwhelming immune response. The virus triggers in immune cells to release large amounts of pro-inflammatory cytokines, which causes damage to the endothelial lining of the lungs due to tissue repair process inability to keep up, resulting to the major damage to the lung tissue, causing the acute lung injury, ARDS. ARDS, this infection is characterized by the damage of alveolar and capillaries, increased collagen and fibrin deposition, increased cell permeability, and ultimately became the cause of death for this patient. In severe viral lung infections, local inflammatory cytokines can enter the bloodstream, resulting in systemic inflammation in a condition that mimics sepsis, and can result in multi-organ system failure. And the treatment for the cytokine storm has been proven to be extremely difficult. This could lead to microvascular thrombosis, fluid leakage, and alveolar collapse. Inflammatory markers and coagulation abnormalities like the patient's elevated INR and low platelets support this diagnosis. Once this process becomes systemic, it resembles sepsis, leading to hypotension, shock, and multi-organ failure. The lung fail, oxygen delivery drops, and the heart eventually cannot compensate, hence the cardiac arrest. My next slide, why VA ECMO was needed. The patient was beyond the point of conventional ventilation. ECMO functions as a bypass for both the heart and lungs. Oxygen-poor blood is drawn from the venous system, oxygenated through a membrane, and returned to the arterial system. It helps to maintain circulation and oxygenation in critically ill patients by taking over the function of the organs This therapy is commonly used in emergency situations such as severe heart failure, cardiac arrest, and after cardiac surgery when the heart cannot pump effectively on its own. The process involves inserting a cannula into a large vein, typically the femoral or jugular. To withdraw oxygen-poor blood, this blood is directed through a membrane oxygenator and adds oxygen and removes carbon dioxide. Often the blood is oxygenated. It is pumped back into the large artery, such as the femoral artery or the aorta, to circulate through the body. Relative contraindications consist of evidence, ischemia, neurological damage, congenital cardiac disease, prolonged hypoxemia, and also prolonged mechanical ventilation. Absolute contraindications would include severe dysphagia or ischemia, poor underlying prognosis, and numerous anticoagulation contraindications. This stabilizes gas exchange and gives both the lungs and heart time to rest. It buys time for the underlying inflammatory response to resolve with supportive care.
Thank you, Lynn. And now I'm Renee. I'll be discussing respiratory care and critical care management. So the primary focus of the respiratory care practitioner is to protect the lungs from further injury while supporting ventilation and oxygenation with optimum levels of PEEP and sufficient FiO2 delivery. As we know, this meant switching to a lung protective ventilation, i.e. using low tidal volumes around 4 to 6 cc's or milliliters per kilogram of ideal body weight, and keeping plateau pressures below 30 centimeters of water. The patient's reduced compliance made ventilation very, very difficult, as this patient, young male, was starting to pull limited tidal volumes under high pressures. And this was indicating very stiff lungs, as we've learned, or a fibrotic lung. So we have a restrictive lungs on as our case. So routine arterial blood gas monitoring helped us track his gas exchange at the alveoli and also track his status in general. Any adjustments to the ventilator settings were done accordingly and precisely. So some of the respiratory considerations that we have when we look at the challenges of the ventilator, we have alveolar hemorrhaging. We also have high peak pressures, which means a decrease in compliance overall, the static and the dynamic. And then when we added the ECMO along in addition to the ventilator, we had to also manage the ECMO. And then we had to ensure lung protective strategies, monitoring blood gases around the clock, and then ventilator ECMO coordination with the two. So we also are in mind, keep in mind risk for any ventilator assisted pneumonia or ventilator acquired pneumonia, or ventilator acquired events. And we're also monitoring the levels of secretions. And finally, we look at the hemodynamic instability. And we need to adjust our settings accordingly to reduce any cardiac strain, venous output, and then frequent assessment of VQ mismatch. So go to the next slide here. So when looking at VA ECMO settings, so we need to consider support and monitoring. And with the VA ECMO settings, initially included flows of around 4.6 to 4.7 liters a minute. with a sweep gas rate of 6 liters a minute at a 1.0 FiO2 or 100%, and mediating careful balance between a balance of the ventilator and ECMO support. The ventilator was set to rest the lungs, often with lower pressure and rates, and continuous monitoring, including, again, gas exchange, circuit integrity, and anticoagulation status. Bleeding risk was high due to INR and low platelets, and that meant suctioning and airway interventions had to be cautious and well-timed. So when we look at the assessment chain here, we do our normal assessments when we walk into the patient's room, and then we get a presentation of what the patient is showing us. So some of his signs and symptoms, shortness of breath, he had a fever and a cough. Okay, and that was suggestive of a viral infection, possibly in the lower respiratory tract. And then we concluded that the patient, this young male, was positive for influenza, particularly influenza B. From the chest X-rays, we saw that there was quite a bit of infiltrates. So now, based on the criteria, it was evolving into acute respiratory distress syndrome. And we really had to reassess the airway and breathing for pre-intubation because the patient was now starting to tank. So as he progressed and had an altered level of consciousness with increased hypoxia and an ability to protect the airway, he was then intubated for respiratory failure and being obtunded. So ventilation and oxygenation needed to be addressed. The initial ventilatory failure, hypercapnia, hypoxia. He started to show high peak pressures, suggesting a decreased lung compliance and required increasing FiO2 and ventilatory support. Okay, so after 2 codes, ECMO was also added, and then somewhere along the line, he's development of ARDS with alveolar hemorrhage, reduced gas exchange surface area. Okay, so what is the role in our recovery and the collaboration of the team? So our role extended beyond just the ventilator settings. We have to manage humidification as well, secretion clearance, and collaborated closely with the perfusionist, the intensivist to optimize ECMO performance. Regular bronchoscopy was condensed due to the hemorrhaging and the burden of secretion. We also helped assess readiness for weaning off ECMO and mechanical ventilation. This case required close coordination between all parties. So the respiratory care team, critical care, the perfusionists, infectious disease, and the nursing team. And this highlights the impact that respiratory care practitioners' vital role within the multidisciplinary critical care team. So when we look at some of the recommendations, we conclude here. So there was a rapid decompensation from the viral pneumonia, i.e. the influenza B, and it progressed into ARDS and myocarditis. We needed to intubate. So if we were to intubate at an earlier time, we could have, maybe have prevented something from happening and had an effective treatment of any microbes with antimicrobial therapy. That was critical. And then the VA ECMO was life-saving, but required a nuanced therapy in addition to the ventilator management. So both the VA ECMO and the ventilator working together. So the final, key takeaways and conclusion. So this case, very important case, emphasizes how quickly the escalation of influenza B can progress into a life-threatening disease in ARDS and myocarditis. So within just a few days, this healthy young male with no real signs of anything, any health issues, this young adult male became critically ill and he suddenly required intubation. Then after two ROSCs from a cardiac event, a VA ECMO was initiated with full ICU support. And the respiratory care team played a critical role, a central role in managing ventilation and also monitoring gas exchange, supporting airway clearance, and ensuring ECMO was effectively integrated into care. So in conclusion, this is just a powerful reminder to the group, all of us, that the importance of early recognition and taking the proper steps to slow down the disease process progression can be achieved through aggressive intervention and advocating proper care for the patient, and also through interdisciplinary collaboration within the critical care team. Thank you.
Thank you.
Good job, guys.
Okay, that was 20 minutes.
22.
Oh, hey, we'll take it.